and a thank you from Kelly as well. That's the end of our questions, and we're dead on 12 o'clock, Kristalina, so perfect timing. Thank you very much for coming to speak to us and updating us, and we look forward to the further information that you'll hopefully be releasing soon.
Thank you. Thank you. My pleasure.
Excellent. So we are moving on to our next session. I'm just finding my notes. And we will be moving on to hear from Professor Kate Flemming. Kate is internationally known for her research and service innovation in palliative care nursing. And Kate is currently leading the integration of research and teaching in the new nursing curriculum in the Department of Health Sciences, bringing together world-leading researchers and teachers in education as well. And Kate will be talking to us about research in palliative care today, and her experiences of people with motor neurone disease, but we know that this is an area of research where it can translate across different conditions, especially neurological conditions. So welcome, Kate, and I'll hand over to you.
Well, thank you. Excuse me. Thank you very much, Rebecca. And thank you very much for the invitation to speak this morning as well. It's been an absolutely fascinating morning. I've been on the call since 10 and heard the presentations and the questions. I think the quality of the questions that's coming from the audience is just incredible. So I'm just delighted to be with you today. So I guess in the terms of Monty Python now for something completely different. Just a little bit about me. My background is in palliative care nursing, as Rebecca mentioned. But actually, as I've been sitting and reflecting over the course of the morning, the reason I went into palliative care nursing was that my first job, once I qualified as a nurse, was a staff nurse on a neurology ward. And actually, what I discovered there, having not much experience of palliative care, that we didn't really do palliative care very well in neurology, and so I was really keen to kind of understand more about palliative care and how we could do it better. So actually then went to work in a hospice, and that's kind of how I got into all of this and into research as well. So very much driven by my clinical nursing background, but also reflecting across the course of the morning as well. As a carer, I cared for my dad, who lived and died with Parkinson's disease a few years ago as well. So a lot of those challenges that we've heard in the questions today kind of feel very familiar as well. So as I say, delighted to be with you. I'm conscious that it's a topic area of palliative care that can be sometimes a little bit sensitive. What I'm hoping to do today is to talk you through some of this research, to talk you through what we didn't find out from the research, but then also to talk through some of the elements around planning when you're living with a life-limiting condition, and the kind of things you might want to think about. So guiding you through it hopefully in a suitably gentle way, but also being hopefully thought-provoking as well. So I look forward to questions at the end as well, so thank you. So, slide to move on. There we go. So this bit of research is actually a piece of research we did a few years ago, but is still very current. And Megan had picked, research lead at PSPA had picked up on it, and hence I was invited to talk to you today. So the actual title of the research is up here, and that's kind of a little snippet from the article in Palliative Medicine. And there's the link to the article there, and I'll ensure my slides are shared afterwards, so you could got that link there. And just a little bit of a shout out to the team, and particularly to one of the authors, Samantha Bolsher. I'm really keen in all my work to ensure that we've got people with lived experience of conditions involved in the research. And Samantha had cared for her husband who lived with and died with motor neurone disease, and she was really formative in guiding our thinking about the review and how we approached it. And also other collaborators, Bill Humans, palliative care consultant at St Leonard's Hospice, where also I'm a trustee, and the work was funded through Marie Curie, and they did a joint research funding a few years ago with the Motor Neurone Disease Association, which is kind of what drew me into this area as somebody who was working in palliative care particularly. So I thought it'd be helpful just to have we've talked a little bit, and Boyd certainly mentioned briefly palliative care in some of the MDT work that he talked about earlier on in his area. I thought it'd be helpful just to have a little think about what we mean by palliative care. So So this is the World Health Organization definition. There's lots of different definitions out there, but I thought I'd pull on this one. So palliative care and approach that improves the quality of life for individuals and their families, or whoever's important to them, who are living with a life-limiting illness. And what a palliative approach to care aims to do is to prevent and relieve health-related suffering through early identification. We've talked a lot, there's been a lot of talk about diagnosis today and about early identification of disease, correct assessment and treatment of pain and other problems. And as we look across more neurological problems, it may not be so much pain, but other issues such as we've heard this morning. But these may be physical, they may be psychological, they may be psychosocial, or they may be spiritual. So it's very much the holistic approach to an individual in their care. And I think very important to kind of think about is that it can happen alongside active treatment. A palliative approach to care, often it can be kind of thought about as just the last few days of life, or somebody's palliative now is a phrase I often hear. It's kind of a thing, but actually it's a whole approach to care that can happen right across the disease trajectory. And how I like to think about it, away from kind of WHO definitions, it's about supporting people to live and to die well with a life-limiting condition. That's what we're about in palliative care. The founder of the modern hospice movement, and not all palliative care happens in hospices, is a helpful thing to think about, but the hospice movement has helped drive the profession of palliative care. And I think this quote from over 20 years ago by the founder of the modern hospice movement, Dame Cicely Saunders. In 2022, she was saying, oh, maybe in 10 years' time, we'll be able to do things better in relation to diseases other than cancer. The hospice movement's largely concentrated on cancer. We need to look at other things, at what we can do for people with strokes and motor neurone disease. So she was thinking ahead even at this point. We need to go on learning so that in 10 years' time, we're doing things better than we are now. I would say we're still on that journey. And I think as I go through the review that we did, you'll get that sense also. So we need to keep pushing forward. We need to keep raising the profile of palliative care in neurological disorders, and actually how things can work really nicely together. There's some great examples of where that happens. So there's been quite a lot of talk of motor neurone disease this morning and the similarities. There's just a few bullet points there, which I'm sure will be familiar to many of you, because it sounds as if in the PSPA world that this is kind of quite a common language. So it's a neuro-degenerative disease, as you'll be aware. It has quite a sudden onset with rapid progression, brings with it potential for real complex and disabling symptoms and care needs. There's a challenge around diagnosis, and that bottom point says delays in diagnosis can actually end up counting for a significant proportion of the total disease duration, and hence the average time between diagnosis and death is 2 to 3 years. And often progression can be over weeks and months rather than years. So there's a real challenge about keeping up with, Boyd mentioned earlier, it's about wheelchairs. Actually, by the time you get the wheelchair, actually, is it the right wheelchair? Have sort of symptoms progressed and the condition progressed? So real challenges around it. I just wanted to also touch on a little bit about what a systematic review is and why we did it. So this is the review we did, it wasn't brand new research. What systematic reviews do are summarise the results of available good quality studies. So these are, a systematic review looks for and searches for studies that have addressed a particular issue. In our case, it was looking at palliative care needs for people with motor neurone disease. And it uses a really systematic approach to try and find those studies, and has really systematic approaches as to how we combine or synthesize them together. It's the kind of research that the National Institute for Health and Care Excellence uses, NICE, when it's doing appraisals. And there's lots of different approaches that you can use and lots of different types of research that you can put into a systematic review. Most commonly, or very often, and how the whole approach started is through systematic reviews of randomized controlled trials to try and work out what works in healthcare by pulling lots of trials together. But equally, some of the work I've done, and I always call it my nerdy methodological side, is to develop the ways that we can pull qualitative research together and pull it to get this greater understanding from existing research. and how we can consider connections, similarities and differences between the studies. And why? Because actually pulling together research, we can often get much more information than the findings of each individual study in isolation. So it's a really kind of good way of using existing research. And I always talk about it as also kind of enhancing the contribution of people like yourselves who take part in a single study, which is really valuable. Actually, if we can then make more of that contribution by pulling that research into a review and comparing and contrasting across research, it makes more of your individual contribution as well. So that's the approach we used, and a little bit about it as well. And so finally, the final bit of it, why qualitative research? So this was a review of qualitative research. Now, qualitative research is a particular approach to research or a research methodology that seeks to explore perceptions and views of individuals. So it's really important that we know about what works in terms of treatment, what can help improve symptoms, what can help life expectancy, but it's equally really important to know what it's like to receive that treatment, perhaps from a healthcare professional's point of view, what it's like to deliver that treatment, how that fits alongside other things. So it's really, qualitative research is really helping us understand more about people's experiences of their situation, their illnesses, the services they receive, and all of that. So synthesizing or combining qualitative research can really help maximise the contribution of primary qualitative studies to help underpin that evidence base for practice. And we heard very early on from Boyd actually how the evidence base for practice can help inform commissioning of services. So it's really important as part of that whole piece together. So that's that. Okay, so what did we do? We looked for published research, and there's particular healthcare databases that you can look in that are set up to scan and find existing research. We found about 403 different results, and then we sifted those down to the things that were really relevant, because often you'll find stuff that isn't relevant, and we included 40 papers in our review. So quite notably, of those 40 papers, they included the views of 354 people with motor neurone disease and 369 carers as well. So we were interested in carers' perspectives also. And these are from lots of different countries. We didn't limit to where we got papers from. And here you can start to see the value of doing a systematic review, that actually perhaps an individual qualitative study, they often have quite small numbers in them. So Rob was talking earlier of kind of 60 to 80 people in the trial he's doing. We may only have 15 or 20 people in a qualitative study. So actually looking at lots of different qualitative studies that have addressed a similar question, we get lots more people involved without having to go out and interview and speak with more people. So you can see there in the two tables at the bottom here, the kind of age range of people with motor neurone disease and their carers. So real spread of people that were included in the studies that we pulled into the review, almost an equal split between males and females, slightly more female carers. That's quite common as well. You can see here some of the challenges around time to diagnosis. Some are quite quick, some 60 months, 5 years to getting a point of diagnosis. And then just a little bit about the type of carer here. So most people who were a carer were the partner, some were a child, some were another, such as a parent. And again, quite a long time there as a carer, between 6 and 96 months. And then here on the right-hand side, I thought it'd be helpful just to see some of the geography of where the papers came from, predominantly UK studies, which is really helpful and really great to see that this research is being done in the UK, but also Australia, Sweden, Ireland. There was a number of papers from in the US, and then one paper each from Germany, Canada, Italy, Japan, Netherlands, and Norway. So a real kind of breadth of experience as well. So when we pulled the papers together, we found out an awful lot about people's experiences of living with motor neurone disease or caring for somebody with motor neurone disease. And those experiences were right across the trajectory of the illness. So once people were diagnosed, there's a lot of information about response to diagnosis. There's also information about how trying to maintain control over the disease, and particularly around that kind of rapid progression that can happen of actually, you know, sometimes people feel like they've just got on top of something and then something else happens, which may feel familiar to you as well. So that sense of trying to keep control. Some of it was around when deterioration happened, about decision making. So whilst this doesn't particularly talk directly to palliative care, this is one of the things I'll be coming back to towards the end of this presentation, about actually how palliative care can help with some of that decision making around deterioration and some of that planning ahead. Some of the challenges were talked about engaging with professional support, and there was kind of talk earlier on this morning about challenges of engaging with GPs, the lack of knowledge around GPs, and all of that came out through this review as well. But actually, whilst the focus of the review was palliative care, there were very few reports of palliative care across that trajectory. Most of it was around planning for end-of-life care, so those last days and weeks of life, and people, the carers in particular, talking about their experiences of end-of-life care. And there was also some talk about interbereavement as well. So end-of-life care, palliative care was often associated really very much with the dying phase only. This is what we found through the review. And some of the life-sustaining interventions in motor neurone disease weren't related to a palliative care approach at all. So earlier today there'd been talk about feeding tubes, and so that was talked about a lot, whether or not people would want feeding tubes, but also about non-invasive ventilation. And often these things were only talked about at the time when real crises happened and there wasn't that kind of planning ahead. Most of the talk of palliative care was associated with treatments that would alleviate suffering right towards the end of life, so real kind of symptom management around the dying phase. Interestingly, in countries where it was legal, assisted suicide and euthanasia were freely talked about by both patients and carers and potential options. And clearly, it's way beyond what I could talk about today, but the kind of political environment and the talk around assisted suicide is got much more traction now in the UK, and various bills going through various parts of the UK, the devolved nations parliaments as well. And it was about maintaining a sense of control in essence when it was talked about, and a wish to die before the final stages, and real kind of thoughts about suffering at the end of life, and which is actually one of the areas that palliative care can really help with. So people had real kind of serious concerns about the lack of knowledge amongst healthcare professionals, both in acute services such as hospitals and community services. And this really, and that was a lack of knowledge about motor neurone disease. Again, you know, a GP may only see 1 or 2 cases across their career. But this really impacted on families' willingness to engage with such services and hand over care and trust others. And it was really about trust as well. There's a real sense of inexperience, sorry about the typo there, or lack of knowledge from palliative care services about people with motor neurone disease and their needs. And this quote here, which is from one of the papers by O'Brien and Preston, actually kind of really reflected one of the comments that somebody, one of the questions and observations somebody had put in before about just the last 3 weeks of my mother's life. It was terrible, the lack of knowledge, incompetence, not knowing, and the lack of knowledge around motor neurone disease. So some really kind of challenging experiences. And family carers really struggled to find answers to their questions about the dying process, and dealing with a multitude of service providers really added to the confusion. And again, earlier there was talk of kind of a single point of contact, and about that real need for a single liaison person. So planning, it was felt through all the people that were kind of interviewed in the studies we included, there was a real need for information for people to help make decisions regarding end-of-life care. And it was really just commonly perceived to be lacking. I'd like to know how it would be managed, what my choices are, was a quote from one of the studies. And so an individual themselves saying, I don't want to die in hospital unless it's absolutely necessary. But if that planning is not in place, then people tend not to know what people's wishes are. So there was a little bit about where discussions may have happened between a patient and their carer, but it wasn't really very common. It wasn't much talked about in those studies that we included. People saying they think we were in denial for quite some time. We knew it was coming, but we didn't plan. So I think some of what I'm going to talk about next is about kind of opening up those conversations, because what we found was where they had happened, really positive experiences were reported. Plans were made, carers were able to see achieve some sense of comfort of actually, well, he told us everything he wanted. He'd always done through the last year. He said, you know, this is what I want, this is what I don't want. So when somebody does deteriorate, you've got that sense of what's wanted and have some more control over that. Sometimes where planning did happen, plans weren't always communicated effectively between healthcare professionals, so this is a real challenge as well. So ensuring that things are documented is really important. And I know certainly from my experience, I talked about caring for my dad, actually ensuring that the not for resuscitation order, the DNA CPR order, stuck with him whenever he was admitted somewhere was really challenging. And I would always go and say, have you got this? Do you know about it? So even when plans are made, it can be some effort to keep them kind of live and known about. And some of the challenges around living with a neurodegenerative illness raised expectations that a person would die probably of respiratory failure, but actually, because it hadn't been talked about so much, it was often more sudden that it may not have been that it was an acute event. So again, having healthcare professionals who are confident to have those conversations with you is really important as well. So I'm conscious of time. It's really important, and what I wanted to do is not just say, you know, that some people didn't have a great experience and just leave it at that. So I wanted to just kind of touch on some of the importance around planning ahead and discussing end-of-life care. Some of it's around breaking that taboo. I've got a really good colleague and a great author, Catherine Mannix, who I refer to at various points in the next few slides. Catherine has written a number of pieces around talking about death, having conversations, and I've got a whole bunch of resources at the end. Catherine's really trying to open up kind of how we have conversations, even if you're not living with a life-limiting illness, but actually, how do we talk about what our plans are? And I love this quote from her book, Listen. She said, talking about death won't make it happen, but not talking about it robs us of choices and moments that will not come again. And she talks about having informed choices and actually how crucial it is for discussing, having open conversations, just for having better preparation and understanding of individuals' preferences and values. And by actually having these discussions, both as healthcare professionals or with your healthcare professional between yourselves, you can start to take some control over your end-of-life care, ensuring your wishes are known, that they're respected by family members and healthcare professionals. So there's a real sense of empowerment that will come from it once you get over that, oh, this is a tricky conversation to have. So Catherine just had a piece actually in The Guardian at the tail end of last week, which was talking about end-of-life care, in particularly for people who are elderly. And she said, I'd run this article past my parents who are 90 and 96, that I thought it was really timely, and I just wanted to bring some of it in, and the reference to it's on the next page. She talks about, let me walk you through the ideas it's helpful to have discussed as you live with a life-limiting illness. Some of it's around where you'd like to live and be cared for over that period. And thinking about some of the things that would matter to you most. And this can be as broad or as narrow as you like, including people, pets, places. Do you want TV, access to music, books, hobbies, your place of worship, your cultural customs? It might include about how your attitude about thinking about accepting help with washing, dressing, eating, getting help around your home, how you get around your home. You might really value being highly independent, or you may already be benefiting from aids and appliances and people who assist you. And how would you like that to be as things move forward with your illness or as you get older? And equally, the link to the Guardian article is there and it's freely available. Thinking about what quality of life means to you over the last year or so of life, what would the priority be for how you live? And is it quality? Is it quantity? What kind of tolerance do you have for discomfort and intrusion, for a chance of a few extra days survival or longer survival, and those discussions around things that can enhance potentially quality of life and quantity of life, but maybe quite intrusive, such as feeding tubes that we talked about earlier. Actually, would you rather decline invasive treatments that may extend your life but not add to its quality? And actually, what might that look like? And perhaps maybe somewhere your decision would be between the two. And then thinking about who knows your wishes, who will speak for you. and nobody can speak on your behalf unless you give them powers of attorney, and there's information on the NHS website there. So it's just a few bits of kind of how palliative care can start to help planning through this whole trajectory of illness. And we often talk about hoping for the best, plan for the rest. We're really pragmatic in palliative care. We're solution focused, we're communicators. And just to kind of bring you back to Cicely Saunders, who was the founder of the modern hospice movement. And I really like these two bits that she is quoted here. You matter because you're you, and you matter until the end of your life. And there's everything we can do for you if we're imaginative and we work at this. And it can be challenging sometimes, but equally, there's an awful lot that palliative care can do. I'll just leave those there now as some of the recommendations to review. I've kind of touched on them about reframing palliative care to the point of diagnosis and ensuring there's prompt access to palliative care, encouraging health professionals, so us as health professionals, encouraging other health professionals to be confident about having advanced care planning conversations, preparing for the next stage of the disease trajectory should take place during the phase before, and particularly in relation to the introduction of those interventions. Everything's got to be about individual variability, and also thinking about how we support carers. Here it's talking about motor neurone disease, but carers in general is really important. So just some resources. I've got a few minutes over my 20, but we've got a couple of minutes for questions still. Hospice UK have a hospice care finder, so you can find, if you put that in, you can find a local hospice, your nearest hospice and the services they provide. But palliative care also happens in acute hospitals, is the role of district nurses, and in general practice as well. There's a link to the NHS website on lasting power of attorney. And then an organisation looks at what matters conversations and some of the resources around that. Marie Curie's got a great website around planning it, starting to plan ahead. There's links there to both of Catherine's books. They're really interesting reads. I read them as a palliative care professional. I know many people who are not, who are nothing to do with healthcare, who found them really helpful books. And then very finally, and I see it's come into the chat as well, there's a link to the PSPA. There's an episode around advanced care planning on the PSPA website as well. So that's me. I'll stop sharing there. Sorry that I went a little bit over, but I hope you've got a few minutes.
That's fine. We've got a little bit of extra time. Kate, Mark doesn't think he needs quite as much. So
okay. So I always get too enthusiastic. I'm sorry.
No, it's great, and it's certainly interesting to learn across diseases, because sometimes there's some learning that can happen from different studies for different illnesses. And but the first question was actually around that, from Dina saying, well, the data seems to be, and she's right, about motor neurone disease.
Yeah.
Is there specific PSP data, or how closely does MND data relate to PSP in this instance?
Yeah, that's a really helpful question, actually. And again, and a number of times we've heard this, it comes down to the funding of, this was a call from the Motor Neurone Disease Association and Marie Curie, and hence that was the focus of the review. I think any of the components I've just talked about, I think that, a palliative approach to care, it goes across any type of illness and disease trajectory, and it's the principles around that can be adapted to any particular type of illness. So I wouldn't say any of what I've talked about is specific to motor neurone disease. That was kind of the focus of this review. I think what was interesting is that when you start to look at when something is essentially terminal at the point of diagnosis, and we know it's life-limiting, that actually there's a role for palliative care right from the beginning, around that planning, around that integration, and around working in that multidisciplinary team that we've heard about across the morning. So whilst the actual experience is talked about here from people living with motor neurone disease or their carers, I think there's a lot of resonance from what I've heard across the morning. So I hope other people can take that too. I hope that's helpful.
Yeah, definitely. Thank you. Kelly, a thumbs up from Kelly about the books, saying that actually they're really good.
Oh,
books.
cool. So somebody showed
These books are good. So
okay. Brilliant. Thank you, Kelly.
So also do you recommend, from Edward, do you recommend early engagement with a local hospice whilst living with PSP?
Yeah, I would. I'm obviously a real advocate for palliative care, but hospices are there not just for the end stages of life, nor is palliative care just there for the end stages of life. Different hospices offer different services and facilities, and that's one of the reasons I put the hospice care finder there as a link. So I would certainly encourage those conversations. Many hospices will have a self-referral route in. Sometimes it's through your district nurse or through your GP. Hospices offer carer support, they offer social worker support. There's lots of things that can, I know there's talk earlier on about challenges around continuing healthcare, funding. Often hospices can help support with applications for those. So the multitude of different ways that hospices can provide additional support and care alongside whatever you're receiving through kind of fully funded NHS services and other services as well. It sits as part of the healthcare system, and it's really complementary to it as well. So I'd really encourage people to take that step and have that conversation. Sometimes it feels like really quite a hard step. Kind of, or if I'm going into the hospice, that means that, you know, I'm near the end of my life. Other people, family and friends can be, we know that people can be quite resistant. You're not there yet, you're not at that stage, but actually what we do know, there's a real help and support that's available right through the trajectory of an illness. So, yeah.
Yeah, I think it's a really good point. It does come up in our carers groups. You know, people give examples of where they've accessed hospices and have been hugely helpful.
Oh, brilliant, that's great.
So I think they're a bit misunderstood in the way that
Yeah.
they've developed over the years. So
We're working on it.
do any harm to ask how they can help and support you if you've got PSP or CBD.
Yeah.
Maybe many ways that they can along that journey. Kelly, sort of point to note from Kelly, they had lots of discussions with hospices in diagnosis, but it was hard as I had to put my mum into a care home as I couldn't do enough for her. So carers need to be prepared for the guilt when they may fail to deliver your loved one's wishes.
Yeah. And that's really, really challenging. Increasingly hospices and other palliative care organisations are working with care homes to help support education for staff working in care homes who can deliver really great palliative care as well. It isn't limited to being in a hospice or specifically to hospice services, but and quite a lot of care homes have palliative care beds as well, so there's that knowledge within the care home as well. So it's about a whole sector-wide approach to palliative care as well, and ensuring, and it's a huge amount is about those conversations and about the planning and having the confidence on both sides to have those conversations, for sure.
Yeah. Question from Phil, which he says it's probably more for me than it is for you, Kate. I'd like to thank Kate for a brilliant and thought-provoking presentation.
Oh, thank you.
My question is probably more for Rebecca. Or have PSPA thought of undertaking a systematic review of PSP stroke? Sorry, the questions are jumping here a minute. PSP stroke tau protein research. I'm aware of the Chinese have undertaken a bibliographic review to focus areas of research. Surely AI could make I'm going to assume that makes a significant impact in such a review. We haven't done that, Phil. It's a good suggestion. I'm sure it's something that perhaps the research committee could consider. We will be releasing some small grant money in September, and we hope next year to have some more significant sized grants available for research as well through our research appeal. And that may be when we issue those grant calls, we can be quite directive in what we want people to do. So certainly, Megan, who's on the call, the research coordinator, Megan, if you could just put that on their list as something to think about and to look to see what else is happening in the world. It may be somebody else has done it and we don't need to.
Always worth a look. I was just thinking actually, well, I could do a quick look on the Cochrane. Cochrane's a big collaboration that does systematic reviews. If there's anything there over the next half.
Yeah, and we do bring, so last year we brought about 250 researchers together from across the world in London with our American counterparts, Cure PSP. Some of the people on the call were there. So we do try to sort of cross-fertilise the research that is going on so that we can ensure that the researchers are learning from each other and we're not repeating bits of studies as well. So we have
Sure.
people from India, America, Canada, Spain, all over the world ready to contribute to that. Let me just check if there's any other more questions. Beth. We've had excellent care from our local hospice who are geared up to deal with long-term conditions, especially physiotherapy and visits from volunteers to come and sit with me, very local too. So a thumbs up from Beth for how good that support can be from a local hospice.
That's great to hear.
Yeah, so I mean, for other people, it might be worth thinking about.
Yeah.
And Kelly just says, yeah, it's ridiculous. Hospices aren't funded by government. They are amazing. And I know some news articles recently about the sort of funding crisis for hospices.
That's a whole other debate we could have.
Yes, exactly. Excellent. Thank you ever so much, Kate. It's been lovely to meet you.